Great. Welcome back, everyone. We are still in the House Healthcare Committee. It's the afternoon, and we have an important conversation in front of us. The Department of Mental Health is here to talk about their budget adjustment request. We also have in the room Tiff. Tiff comes from the House Appropriations Committee, and her portfolio includes Department of Mental Health. Tiff, if you have questions, raise your hand. I want you to be involved in the conversation. And then I think we have over here an intern. If you want to introduce yourself.
Hi, I'm Olivia. I go to UVM, and I'm an intern for Representative Nato in the House GOP caucus.
Great. Well, welcome. So we're going to dive right in. We only have until 2. So I want to make sure we get through the whole thing. There are questions, just so the three of you know, Daisy and Alyssa are the liaisons we have to House Appropriations, but obviously anyone can ask questions. So again, don't give me the evil eye if I stop questions for a little bit. I'm going to try and monitor the time. And then, like I said before, this is for us to hear and ask questions. We will not be making decisions today. With that, I'm going to turn it over to you.
Sure. For the record, Emily Hawes, Commissioner for Department of Mental Health.
Allison Crum, Deputy Commissioner for the Department of Mental Health.
And I'm Shannon Thompson, the Financial Director for the Department of Health.
So how we've been approaching our BAA testimony is to go through the line items for the budget adjustment. And so I'm going to turn it over to Shannon for her to lead that. And then we can work our way through those different items and see where we get to.
Great. So are we doing the narrative talking points or something different? I want to make sure we're all working off the same page.
Yes, absolutely. So the talking points should follow the ups and downs. The ups and downs, you probably have a colored version of this. If folks don't.
Get that.
Over there.
Okay. Is
I
it?
believe AHS sends them.
So Claire's going to send it out. Is it possible to also put it up?
Sure. I also have hard copies.
Oh, hard copies would be fabulous.
I like hard copies.
Let's do that.
Wow, that was quick.
Trying to hide the hard copy.
So, and Bobby, can you read it online? Or Claire will send it to you.
Did she already send it through an email?
Yes. So we're not going to, well, people are watching. We should put it online as well. So if you wouldn't mind pulling it up, since we have people watching on YouTube, it would be helpful. If it's also, sorry.
That's fine. Let me see if Nicole can do it.
Okay. I think it's just helpful to. Right, I meant on the screen. Yes, I meant, is it possible for you all to connect and put it?
Yeah, I'm gonna see if Nicole can do it.
Great. So we can get started. I don't want to hold us up, but that would be helpful. And this is the first time for some going through this type of budget. So may also want to start with how things are laid out on the spreadsheet for us, and then start walking through the items.
Okay, go ahead. So the spreadsheet here is the ups and downs. Basically, the top starts with our current FY23 budget, and then it builds on that. So there are mainly ups. There is one down here. And then the columns that have GF, SF, IDT. The GF is general fund across the top. SF is special funds. IDT is interdepartmental transfer funds. FF is federal funds. And then the next two columns are Medicaid. One is Medicaid program, and then the next is Medicaid investment. And then, of course, there's the total column.
What's the FF? It's
Federal.
Thank you.
Federal funds.
Great.
And general, and what was that again?
General fund, SF is special funds.
Special, okay, thank you.
There are no special fund ups here, but I can explain what those special funds are if that's something that's helpful to you.
So may I ask?
Yes.
When you're talking about ups and downs, ups means you want more money and downs means you don't need it. Is that what I'm understanding?
Ups means we're requesting more money.
Yes.
Downs might mean there's an offset or you no longer need the funding.
Okay, so asking for more money generally.
Yes.
Got it.
And INVMT is investment global commitment?
Correct.
Okay, great, thank you.
All right, are we good with the basics on this spreadsheet?
Any other questions?
I think we're good.
Okay. So the first section here, we go through personal services, operating and grants, and those are sections that are also in the Vantage budget system. So that's why it kind of aligns with that. The first personal service item here is the University of Vermont Medical Center contract increases. With our facilities, we contract through the UVM Medical Center for our psychiatrists, and I'll let our officials explain a little bit more about that.
Sure. We currently contract with the UVM Health Network for our psychiatry coverage at the Vermont Psychiatric Care Hospital. That's the 25-bed hospital that DMH operates here in Berlin. We also have utilized that contract for psychiatric services at MTCR, Middlesex Therapeutic Community Residence. Additionally, that contract pays for a medical director of the hospital, as well as other ancillary medical services, say like a hospitalist or something like that. So that contract did see increases in order to stay in line with other physician salary increases across the healthcare system. That contract does end at the end of March. It's currently out for bid to seek proposals to take over the psychiatry services at the hospital.
So this 371,000 gross is from, to take us through March, the end of March.
Do you want to answer that? Go ahead.
This 371 gross is actually, it takes us through the end of June. So it's for the remaining fiscal year.
Yeah. Okay. So whoever comes on after March, this would help continue the funding for that.
Mm-hmm.
Okay.
Or if there's an opportunity, or if there's a time where there's an overlap or a transition, it takes quite a bit to transition providers. So we anticipate there's likely an overlap, and that RFP closes at the end of January, and so that will also depend on what will happen to the end of the fiscal year.
Can we have Nicole make that a little bit bigger?
Yes.
I'm sure she's listening.
I'm sure she, and I almost was like, no, she does.
Perfect. Leslie?
Do you expect UVM to submit her, or is that not something you can talk about?
I can't talk about a current RFP process.
Any other questions on that? Art?
Was any of this increase anticipated? I mean, should we not build some of that in normally?
Yes and no. Part of I think in general, healthcare saw physician salaries and medical salaries go up substantially after and during COVID. And so we try to guesstimate as much as we can, but it certainly increased more than what we had originally thought.
So this amount isn't the total increase, it's the increase above what we budgeted?
Yes.
Okay.
Can you tell us what we budgeted?
Shannon, can.
I can certainly get you that information. It's in the area of a little over $2.5 million probably, but I can get you the number if that's helpful.
I'm just thinking about what percent.
Yeah. Yeah, if that's helpful, I can certainly get that information.
That would be helpful.
All right, travel nursing.
Okay, the other thing that I should have pointed out for you, if anybody is looking at the talking points here, there is a gross amount and a general fund equivalent.
Which one?
So, yeah.
Okay.
Probably.
No, not that one.
It's not that
No,
one.
not that one.
It's online.
It's online. So DMH set our talking points up so that you can see how much general fund is required in order to fulfill the request. So it's the gross amount and the general fund equivalent. So the travel nurse contracts, there's a gross request of 11 million actually, 245,843, which has a general fund impact of $10,502, $540. So this represents the estimated cost of the travel nurses above what we have. And DMH has been utilizing these travel nurses quite substantially compared to years past.
I'm sure there will be some questions on this, Alyssa.
I mean, I think that's my only question really was, I mean, I remember us talking during the budget last year. We knew we were going to be utilizing traveling nurses. How many more traveling nurses did we need to utilize above what we had budgeted that it's $11 million?
Sure, and we can get back to you on that. That's a good question. So last year we testified about a couple of things. One, travel nurse cost, and then a plan to offset some of that with recruitment and retention with our permanent staff. And so we were able to go through a market factor analysis and also shift differential increases for permanent staff. And that closed the gap a little bit. But the travel contracts have not decreased at the rate that we would have liked to have them decrease. So we're still filling almost, I think it's almost 65%, is that right?
Of positions.
We're filling 65 of the positions at the hospital with travelers right now.
Can you talk just a tiny bit about the retention and of recruitment?
Sure. So we did a $5,000 sign-on bonus. Folks got $2,500 at the onset and then $2,500 6 months later when they completed probation. That's specific for nurses. I believe for our mental health specialists, theirs was $1,500 split in the same way. But let me get the exact amount for that. It was a lower amount than the nursing positions. And that did help us sort of stop the bleed, so to speak, in that we had many resignations. And, you know, it's still possible for folks to be a traveler and be a Vermont resident and then work at a hospital that maybe you worked at as a permanent staff not long before that. And so that gap continues to be large, although we are decreasing those travel contracts over time. Those are coming down and we're able to contract with travelers at the same time hire. We're seeing some folks come in through the permanent staffing. So that is our hope. We want permanent staff to be hired there. It makes for a safer facility and a higher quality of care. Not to say that travelers don't deliver a high quality of care, but there's a risk to that for stability.
Just really quickly, we're at 65% now. Where were we a year ago?
So does it say in the talking point?
Pre-pandemic, it says 8 to 15%. Is that the same thing? Is that what you're talking about?
Well, I mean, I'm thinking a year ago when we had the discussion about recruitment and retention.
This time last year.
Yeah.
Yeah, I don't think we were, let me get back for specifics on what we were this time last year. From my recollection, it was likely still very high. I don't think it was 65, but my guess is we were in the 50% range last year.
Daisy? And then
So, just so I'm sure I'm understanding the talking points correctly, is it that we have increased both the number of travel nurses as well as the cost of those contracts went up?
Correct. Yeah.
That's correct. And then the second question is, will the workforce bill that passed last session, do you think that will begin to address some of these issues? Is that an off-ramp?
I think it could be. Yeah, I do think it could be. I think as the traveler contracts start to come down nationally and across healthcare, we'll start to see that be a little bit more competitive for a permanent staff versus a traveler looking at the same position, the same qualifications.
Last question might be for Shannon. I know there was a portion of that that was global commitment funds. Can you explain why there was a portion?
Yes, so the reason that you're seeing general fund and global commitment fund is because this is across both of our facilities. And VPCH, the Vermont Psychiatric Care Hospital, is an IMD, an institution for mental disease. And because of that, we are having to phase down our Medicaid funding. So all of the funding that you see under the general fund column is associated with VPCH. What's under the Medicaid column is for the current MTCR, Middlesex Therapeutic Community residents, which will be the River Valley therapeutic residents and soon. Does that help?
Art?
Yes, I just want to make sure I understand what this is telling me.
Sure.
So the $10 million for the travelers gets us through the fiscal year. Is that what?
Correct.
So is our spending right now for that item in the red, or is it tracking, but we need this much more to get us to the end of the fiscal year? Is that kind of fair to say?
So we need this $10 million in order to be able to cover the cost of our budget. So we don't have.
Right, no, I understand,
Yeah.
but right today, on, what day is it, 18th?
Mhm.
Are we in the red on that item? Or I know you
That's
probably don't know.
a really good question. I would have to get back to
All
you.
right, you don't have to. I'm just trying to understand exactly how this tracks to the end of the fiscal year.
Right, because obviously we developed this budget
Yeah.
a couple of months ago.
Yeah, correct.
And so it takes time, and then has something changed from that point to today.
Okay,
And I need to get
yeah,
back to you.
that's fine.
I have one question. If we do not fund this or reduce the funding, what does that mean for the care you provide?
It means that we decrease the amount of nursing staff that are in the facility, and closes beds.
And is this allowing us to keep all beds open, or are there still some that are closed?
There's still 4 beds closed, but that's currently related to the availability of physicians. So we have a decrease in psychiatrists that are available to provide services there. We're currently utilizing 2 locums, an interim medical director, and then another full-time psychiatrist. So they're at 21. Their goal is to get to 25, and we'll see some shift in travelers, but it takes just about as many staff to do, from a nursing standpoint, that would be maybe, 2 travelers or something like that, or 6 for 24/7, so.
And do you foresee us being able to reduce our reliance on travelers in the near, mid, or long term?
It's our number one goal.
Sometime.
I think it takes all of healthcare to really explore a system that is set up to survive with travelers. Not only from a nursing perspective, but from a physician perspective, and how that is impacting a hospital's ability to recruit in many ways. Not always, but in many ways. So that's our primary goal. We want permanent staff.
And I do see that it says in the talking points, the costs have increased by about $100. And is that because of the contracts with the travel agency are increasing the costs?
Yes, so in July of 21, those travel contracts were around $76. And the traveler doesn't get, that's not dollar for dollar. Some of those that's included, that goes to a recruiter or to the larger agency where the particular nurse or staff member comes from. So we saw those jumped to $100 2 months later. And then I think the highest that we got to was $225 because the pool essentially dried up. So we are seeing that come down from that $225. We have to balance bringing those costs down with being able to get folks to sign contracts or sign on as a permanent staff member. So those are slowly coming down. That's the hope, is that they get back down to somewhere around pre-pandemic, although I don't know if that will.
Okay, that sounds good.
Well, you asked my question about beds, so thank you. But that brought up another question, which is, and I'm sure you don't have this number right now, can we get a sense at some point of permanent staff that are leaving and becoming traveling nurses?
Sure.
Percentage wise?
I think we can give a guesstimate. We don't always know what happens after somebody leaves, but I think we have a pretty good idea of some folks who we know have left and said they're going to be travelers.
What percentage do you think?
I don't have a percentage, but I can check with the facility.
That would be great.
That. And it'll be a guesstimate. It won't be the actual.
And so the next item, at least on the talking points, I think pertains to travelers as well. Do you want to touch on that?
Well, that's vacancy savings for our nurses. So because we have more travelers, our vacancy savings rate is higher. So we needed to offset the cost of the travelers with some of the vacancy savings that we're seeing.
Jim?
Perhaps this is not germane to our discussion and it's more of an appropriations thing, so feel free to cut me off. But I'm sort of curious why, why is that in the investment global commitment fund versus being in the general fund? And that part is confusing me a little bit, why certain things are in certain columns.
That's a really great question.
Yeah.
Yes. So the reason for that is because the money was originally appropriated in the Medicaid investment column because we were paying for all of the Vermont Psychiatric Care Hospital with Medicaid or special funds. And now we're beginning to phase down into general fund. So any additional cost associated with VPCH needs to be general fund. But we're releasing the original Medicaid cost.
Great, thank you.
Leslie? Yeah, Mike, similar question. Can you help me understand when you say general fund equivalent is 1 million, et cetera, what does that mean?
Another really great question. That is because in Medicaid, there is a portion of that is general fund and a portion that's federal. And I believe it's 38 point something cents. I can't remember off the top of my head. Of that dollar is general fund. So we like to show you how much general fund is required overall for that expense. Does that help?
I am looking ahead and realize I do. And none of the rest of the items aren't important because they are, but they are much smaller dollar amounts. And I think we have something on the table that should come next in line. And so if you don't mind, I don't see it in the talking points and I don't see it in the chart. But in the BAA language, there is a request for $9.5 million for youth beds. So I think it would be great if we can go to that conversation now and come back. So I want to make sure we don't run out of time for that conversation.
Sure, yeah.
Thank you.
Do you want to do the lead in and we can talk a little bit about where that current project is?
Sure. So this $9.2 million is for a youth inpatient, and
I'm sorry, it's 9.2?
9.23 maybe?
2.25, I think.
Okay, thank you.
9.25.
Oh, thank you.
And that's being appropriated or requested as appropriated through a one-time DEPT ID, so it is not showing on the ups and downs. So each department has a top level department ID where all of our appropriation sits, and that's our base budget. But this additional funding here is one-time in nature, so they're appropriating it to us as a one-time DEPT ID.
DEPT ID is what again?
Department ID.
Department ID, okay.
That's helpful because it sounded like you said debt.
But I only said, she said death. So
Department ID.
Department ID, what's that mean?
It's just, it tags, will you answer?
All right.
Sure. So the Department of Mental Health is appropriated here under Department ID 31500700000. That's where all of our appropriation sits. But sometimes when we get additional funding, they don't want to give it to us in our base. They want to give it to us as a separate department ID, give us a separate department number, and we can spend it down in that way. So it's just a different number.
Different number than that.
Correct.
Okay.
And it's, yes.
All right.
And it can only be used for that purpose. It's not
Okay,
part of our
yeah.
base funding.
You're right, it's a separate thing to break it out and make it a separate thing.
We're going to hold questions for right now and continue on with what this is for, and then we'll come back, Leslie.
Sure. And we testified last year about this as well. So we have experienced an increase in youth who are needing inpatient care, who also present with complex medical issues. And so psychiatric units who, that are standalone, like the Brattleboro Retreat, and just a reminder, the Brattleboro Retreat is the only hospital in the state of Vermont that serves youth. So they were unable to really serve this youth. We run into this at VPCH if an adult has complex medical challenges. VPCH, or Vermont Psychiatric Care Hospital, has difficulty of adequately serving. But in the adult system, there's access to inpatient care within the medical system. For youth in Vermont, that's not an option. It also, other things that, the department is focused on is improving integration across our system, which also includes access to inpatient care into our medical system. So this was an RFP last year that we posted, had an initial bidder, and then that bidder then needed to pull their interest in the project. And so we reposted it because we still believe that there is a need within our system to increase access to inpatient psychiatric hospitalization for youth. So we reposted that RFP over the summer. We had another lone bidder, Southwestern Vermont Medical Center, and we are currently working on a feasibility study with that entity, which should be completed the end of March, I believe is the estimated timeline for that. And then that will give us a roadmap for next steps. And so when I say roadmap for next steps, SVMC could do a feasibility study and decide that it might not be feasible for them to do it. If that's the case, we would put it back out for RFP. One of the goals of having this line item be in the BAA is so that when we have a winning bidder who can bring a project like this to fruition, we have the money to begin moving on it so that we're not delayed. Because we are seeing that the impact on our youth across our system in needing to have adequate access to inpatient level care. Anything to add from your point of view?
I think the only thing to provide a little bit of context when you think about the type of youth, it's not just those with a chronic condition, but also a youth who may be pregnant, or self-harm is a common need to go inpatient. And if you're somebody who self-harm in a way that could require medical need, these are pretty common. We want to make sure people are going to a safe space and also being able to treat the whole person. So those are some of the pieces that we're trying to fix.
I have a couple questions I'm going to start with, and then we'll open it up. So why 9 point almost 3? How did you get to that number?
Do you want to talk a little bit about that?
Sure. So as Commissioner Haas mentioned, there's a feasibility study. So the cost of that is in there at about $50,000 total cost for that study. But there are also other one-time upfront costs. They need to be able to renovate the building. So there's renovation costs in that one-time money. There's also cost for startup and training. So when they're going to need to hire staff, they're going to need to train staff, and they can't bill Medicaid for those types of costs. So that's a lot of what's in this proposal here.
Okay. And the money will be set aside, or could be set aside in the BAA. Is this ARPA money? Is it so what are the parameters of us being able to use the money, but then also extend it out into another fiscal year?
It's general fund money.
All general fund money. Okay. And so if it was appropriated now and SVMC comes back and says it's not appropriate, we can't make it work, we might be into August before there's another viable, the money will just continue forward.
That is our hope.
Why 9 beds?
We chose, the RFP actually was quite general. We chose anywhere from, I think, 5 to 12. And it takes just as many staff to operate, say, 9 beds as it does 12 beds, or 5 beds as it does 7, depending on the makeup of a unit. And so I think we'll be able to drill down a little further once the feasibility study is done. But when we were thinking about number of beds, we really looked at it both from a need from the system, but also what it takes to staff a particular number of beds, so.
And there's a general concern that I've heard from people, that it's in southern Vermont again, and that's where the retreat is. So if SVMC is not able to do this, the money would be available for someone else that could be in another part of the state.
Yeah, we would put it back out to bid and, certainly we can't control who responds to RFPs that we post. There are benefits, there is a current pediatric urgent care for kids located in collaboration with UCS. With Southwestern Vermont Medical Center, and we can talk more about alternatives to EDs. And that's been a successful program for that group. So it was a good response to an RFP, but we would put it back out and see if another facility wanted to engage in the process with us.
Okay, and I'm gonna ask one last question. I know everyone's jumping at the bit. Do you, in the analysis that, of data that you have over time of youth that need this type of bed, do you have an idea of the percentage that are under the care of DCF? And I know that may ebb and flow, but I'm curious if you have statistics around that you don't know now that you could get to us.
I bet we could dig into that a little bit. I'm gonna look at Allison since she's our data guru.
Yes, we can get you the data for certain, and I would, certainly, just like adults, the vast majority of youth waiting are voluntary.
Yeah.
And so the majority with medical conditions are also voluntary, but we'll be able to tell you that.
So not under the care of DMH, but within Department of Children and Family Services.
So in DCF.
Okay.
We'll see if we have that, yeah.
That would be helpful.
That's another piece about it being an VMC. There's some DCF residential programs in that area that have led to a higher frequency of youth presenting at the emergency department in that region.
Okay.
So that was another consideration for this being a positive.
Down there. And to feed on to that, it might help even just to know of the youth that we've been tracking over the past year waiting, and I can go back and look, but if you have it more readily available, how many of those that are waiting are under DCF care, just to extrapolate a percentage of the total population. So I'm going to go with Brian.
Thank you. So I'm going to start with a complicated question and then get simpler. This is the most important question I've gotten.
Okay.
So, and I might have misheard things, which will make it moot. But what I heard was that there's a need for inpatient beds for youth and adolescents that have complex medical needs, and Brattleboro Retreat can't provide that because of the medical needs. Then what do we do with involuntary youth when they have complex medical needs? If Brattleboro, because that's where we send involuntary youth, so what are we doing for them now?
Yeah.
And I have more questions, but I wanted to start with that one.
No, I think that's a great question. Fortunately, we don't have a lot of involuntary youth, to be honest. And a lot will convert to voluntary at the retreat. But we did see this happen where we had a young person who had complex medical challenges, who was under the care and the custody of the commissioner, and the retreat could not serve them, and they waited.
In an emergency room.
They waited in two places. They waited in an emergency room, and they were also admitted to an adult unit, which we don't want to have happen. We don't want an adult population and youth population to have to be getting care on the same unit. The care looks different. And so that was certainly something that was reflection of the inadequacies of the system. So we want to try to solve that.
And so then, can I ask, I guess, a few in a row? Okay. So then, I think you're gonna say yes to this, but like it's, but it's, I don't know, but it's sort of like, because I'm trying to think, how do I ask this question? Like, maybe this is a more open question.
Okay.
What are the options that you're considering for involuntary youth with complex medical needs in the long term? Because if this solution isn't gonna fill that void, then we still have that problem even with these beds. So what are, and maybe I could incorporate my other questions into that and then stop asking, because I think they're connected. Because then I would say, why more inpatient beds? Why not other models? Why not trying to put pilot projects out for, you know what I mean, to get more, so we can clear more people out of the EDs who don't need that level of care and who could go somewhere else. I think that actually does weave all my questions into one big mega question, which is what I was trying to do. Yeah, so then I'll stop.
But before, I will say, so I'm going to add to my request based on his, to also see the population of youth that are involuntary that would fit into this. So we can really understand the data.
Sure, yeah.
Okay, so now.
No, I think our goal is to divert folks from having to need the highest levels of care in our system. That's a primary goal of the department. And I think we talked a little bit about that last week when we discussed alternatives to emergency departments like a pediatric urgent care for kids. And that would be our goal, is so that folks don't have to go to that level of care. But when they need that level of care, we also want it to be available. And so with that case I was just talking about, that it wasn't available to them. And at that particular time, there wasn't a way to enhance the medical services being provided at a standalone. They don't have a code team like UVM Health Network will have a code team that can respond to the units. Your standalone psychiatric facilities don't have that. And so this is an issue for any adult or human who has complex medical issues, untreated diabetes that can't be managed. Those facilities aren't taking folks who need inpatient level of care, but also have complex medical where there's a risk, where there's not an appropriate medical team to respond. And so, like I said, in the adult world, that's been addressed by having inpatient beds across, not only across Vermont, but also at the different levels of inpatient care. So we talked last week about our level 1 beds that serve our highest acuity. We got into the acuity discussion to the general beds that are in medical centers. And so those teams exist to respond appropriately to complex medical issues. For youth, all of those beds are in one facility, and we need to diversify from that so that they can be adequately served.
There's one more related. Well, it's just that, because I understand that.
Yeah.
That it's a bid. That the current model we're using is we put a bid out for people to bid on, and I know there's probably limited ability to make someone do this. Like to say to a provider, you must create this. But I guess I'm wondering, is there ways to creatively tie funding of existing facilities to creating more options for this in the existing infrastructure? In other words, saying like, we want you to do something different with the money we're giving you already. You know what I mean? Like without naming any hospitals or anything, because there's, like, I can tell you, like, I have a sense of where the need is, and it would be interesting to look at a map and see where the youth are that need the help. Because right now, if the only place we can send people is Brattleboro, and I can tell you, like, that's devastating for a family to have your kid 10 days, 2.5 hours, 3 hours away from you, and it's just not good for the kid, the parents. So I mean, like, is there ways to use our existing funding differently within the existing infrastructure so that we maybe incentivize or, I don't know, like encourage people to like create what we need where we need it. I don't know if that's like a.
No, I think that's a valuable.
I'm trying to do it without naming names.
No, I think that's a valuable conversation for folks to have. I will add that there is Champlain Valley Hospital. It is across the lake, but a youth who's voluntary can also access inpatient care there. That's not the big solution, but that is an option for youth in our northern parts of the state. But your question's a good one, and it's worthy of a follow-up conversation to see if that's an opportunity we can look at.
Art?
Yeah, I want to follow up on that and delve into this a little more. How did you put this out to bid, and to whom did you put it to bid? In other words, how many places did you ask for a bid?
So the Department of Mental Health has a listserv. Whenever we have an RFP that we're posting, it goes out to pretty much every partner we can think of.
When you say partner, what do you mean?
Every
where?
existing hospital,
every existing
I think it
hospital.
went to our VAS partners. I think it went to the designated agencies. We did a mass campaign to get it on everybody's radar.
How many bids did you get back?
One,
You only got one back, and that was
this last round. Yep. We got one the previous round as well.
And not to grill you on this, but.
That's okay.
But when you constructed the bid, was it for rehabilitate or rehabbing an existing facility or building a new one?
We left it open.
Left it open?
Yeah, we tried to make it as broad as possible, but it needed to be connected to a medical facility.
Okay, need to be physically connected,
That was the preference.
physically connected to an existing facility.
Could you send out the RFP to everyone? I know, if it's still on, I read it when it was on your website. I'm not sure if it's still out there, but it might be helpful just for people to.
Oh, sure.
Yeah, well, I just have a real problem with locating the thing in Bennington. I don't, it's just a personal thing. I mean, we got something in southern Vermont.
A lot of people are thinking that way, I believe.
Yeah.
We've heard the other way as well, that people we need beds. So let's keep in mind that although this is tagged in the language for SVMC, it is something they are doing a feasibility study on, and it could be something that opens up to
Understood.
others. But yes, I understand the concern. All right, Murray, and then Topper, and then Leslie.
I was just gonna say the same thing. We can't really do anything about it in this committee right now, but I know families for whom CVPH was not an option for their kid either.
Nope, I hear that.
And I know you know
Champlain Valley.
in Plattsburgh. So I know you know this. I'm just interested in a creative conversation to see what else we can do.
I just have a quick question about staffing.
Sure.
We already know that we're having problems staffing the hospital in Berlin and other places. So what makes you think we're going to be able to staff this?
I think that we'll have the same staffing challenges as any hospital is experiencing right now. Hopefully part of the feasibility study will be a staffing plan. And so that's still in the middle of that, but I anticipate it will be a challenge there like it is anywhere.
Leslie?
I appreciate that question because that was my question and worried that we go through a whole renovation and then can't staff it. So I'm not sure at what point the plug might get pulled, and how that would fit into your thinking.
Joe?
Is it unusual to only receive one bid on an RFP such as this one, or was it?
I wasn't, to be candid, I wasn't sure if we'd get like 6 or 0, to be honest with you. Because the department hasn't put out a bid like this for some time, if ever. So we sometimes get 12 or 15 bids depending on the topic. So I wasn't sure what we would get, to be candid. So we kind of runs the gamut based on what the topic is. But we certainly have had other instances where there was one bidder. I would say maybe for like a medical director or something like that. The specialty RFPs typically have a lower response rate.
And do you have any sense why in this particular situation this was a one bidder situation? Did you hear any feedback from other organizations or even just in your own professional opinion, you know, when you saw the bid, maybe you thought, oh, this is why we got one or anything like that?
No.
We're, shut up, hands. We're hoping to have testimony Friday of some folks that you might want to, potentially that question can be asked again and they might have an answer. Alyssa?
Just really quickly, the 9 beds. I mean, I completely understand the need for this. It's a glaring omission in our system of care. Is the 9 beds basically based on the fact that that's what the one bid that came back wanted 9 beds? Do we need 9 beds for something that we need, but we've kind of been dealing without?
I don't know if folks would agree we've been dealing without very well. I would say that the feasibility study will really hone in on the beds. And I think it's a mixture of staffing and cost that you want to have, and as well as the need for that level of care. So folks will be admitted, should this move forward, who also don't have medical needs, but other beds are full. So I think that I hear your question about why is 9 the magic number, and I don't think it's been decided that 9 is the magic number.
Okay, I have a question and I'm going to turn to Tiff, so everyone else can keep your questions in case you run out of time, write them down. So I have a couple of questions, a little bit related to Alyssa's. If you can provide in some of the data you're going to come back with in writing so we can understand the relationship between staffing and beds.
Sure.
Right? So could we have 2 beds at 5 different facilities throughout the state? Does that work with staffing? If, you know, so do you understand where I'm trying to get
Yes.
to? Okay.
That would be likely more of a facility issue, where we can talk a little bit more about that, but just my first response is it would be difficult from a facility and operations perspective to have 2 youth beds, like at the end of a med-surg unit or integrated into an adult unit. We would just need to think through that. Maybe somebody out there has a creative lens to make that work. But that's my initial thinking on that.
And I would, so I would still love to just see, like, how many staff do you need? How does that work with the number of beds? You said earlier you could staff, I forget what you said.
Yeah, like a
as
typical
well as-
psychiatry caseload is like 8 patients.
Right, so.
And maybe for
Will you
youth,
say
it's
that
lower
again?
than that. A typical inpatient psychiatry caseload for one psychiatrist is around 8. And that may be different for youth. For youth, it might be 4. So we can talk a little bit more about that.
And then with that data, can you also come back with the Medicaid reimbursement rate for 1 day of an inpatient? That would be great.
Sure.
As well.
Do you want us to compare that across other insurers?
That would be fabulous. Thank you. And then my last question is, explain to us the budget process and timeline. So we started with the comment that 9.3 million, because you want to be ready to act when and if we have someone to act with. Talk to us about that timeline and when we're not in this seat and when we're not in the middle of budget. So that
Yeah,
makes sense.
sounds great. So what the current bid laid out was basically a 4-stage timeline. So like I said, we're right in the middle of the feasibility study. And then there were 3 other that included construction, fit out, and then retaining, recruiting staff, and then being prepared to open the doors. And I think all in all, from their original bid was it like 12,000 for all the 4 stages? I can't remember off the top of my head what that was. But I'm happy to come back and talk more articulately about what each of those stages defined. Or maybe I misunderstood.
Yeah, so I'm asking more, and I'm gonna try and answer my own question, and I want you all to step in. So we go through this BAA process, and then we have our budget process. And when we leave here in session in May, we have a budget that starts July 1st. We are not back in this building talking about budgeting again until January.
Right.
And so I'd like to understand, if we're not at this table, we're not able to allocate these funds in the budgeting process, what are your resources to be able to act quickly if and when these beds are determined? I mean, you all have determined they're needed, if we determine they're needed. Does that make?
Yes, I think what you're asking is are there resources available should this not move forward, and there are not.
And in August, you all have a great bid and a person who can start quickly. And in order to make it work, we want to start, construction in October.
We would need to delay that and come back and ask through the budget process next session.
Can you come before the Health Oversight Committee?
Maybe.
Maybe.
Sure.
Okay. That's a maybe. Okay.
Okay.
Tiff?
Yeah, and I'm sorry I'm gonna have to.
Hi, Tiff.
Hi, nice to see you again.
Yeah.
Nice to see you, Health Committee. I have two questions. One, and this may be something that the committee can provide, but I think that our committee needs to understand the universe of youth.
Yes.
Like how many
Yeah.
throughout the state? And what is the geographic breakdown? In terms of where these young people are and the levels of care that they may need. Because one of the things that I have heard in conversations with people is that, there are not just needs for inpatient beds, but as you just said, there are kind of step down options. And I think that Representative Chena mentioned this too, that are also needed. So at any rate, that would be really helpful. And then this is a question for the committee, because this came up in our committee. And the question is also, what is our history of, as a legislature, investing in capital expenditures at a hospital? When have we done that before?
We just did it with River Valley. So we're moving the Middlesex facility to River Valley in Essex, and we provided capital.
Last session,
Right.
last,
That's one by the state, isn't it?
Right, this one by the state.
Yes,
So you're
not
asking for non-state, Tiff?
No, I'm talking about state. And I had thought we had done that as well. So it was a surprise to me, but that was a question for our committee. But now it's confirmed.
Okay.
We had done this before.
Yeah, and I want to be clear in my perspective that, we have needs throughout our system of care. And we need community-based. I believe, and it's my personal belief, we do need inpatient beds. We need outpatient support. We need peer respite. We probably need 10 other things that I am not mentioning. So this is a hard conversation because it is allocating money to one of the pieces, and we need to focus on all of the pieces. And, we'll see that throughout our conversations this session.
And I think the question that our committee would have for you all is this important in the BAA, the fund? Or is this something that should be part of a more, a bill that comes out of this committee that addresses these issues on a number of different levels?
And that would obviously be a question we will talk about collaboratively as a committee, thanks to.
Okay, thanks everybody.
Thanks for being here.
Thank you, I'll talk to you Monday.
We'll do that one too. Oh, yeah,
Did we add beds in Rutland? Remember when?
Level 1.
We have level one beds in Rutland, 6, I believe, maybe 7, maybe 6. And then they have a general unit as well that's somewhere around 25 or 30.
Okay, I'm gonna go with, we're running out of time. Daisy, did you have any questions
I'm gonna hold it.
Okay, I'm gonna go with, I don't know who was first. Mari.
Just a quick comment to your question about the bids. I'm surprised even one entity entered a bid in this environment. Capacity, the capacity issues our existing facilities are having right now and staffing issues. I think it's amazing that one entity stepped up.
Could I comment on that? I'm wondering if it's legal for you to accept one bid.
Yeah.
Sometimes it's a very specific bid procedure when there's not a competitive. It's just something from past experience you might look at.
Leslie, did you have a question?
I'm sorry.
Yeah, I just want clarification for me. I think I heard you say that if those beds weren't filled with youth with psychiatric and medical problems, they would just be used for psychiatric issues. Is that the thought?
So if let's say a youth presents at needing hospital level of care for psychiatric needs. And let's say that they're voluntary or involuntary. If they're voluntary, they can choose to go, let's hypothetically say SVMC. They could choose that they want to go to that unit versus the Brattleboro retreat. That's a choice folks would have. So it's possible, yes.
For those without medical problems?
Correct.
Okay. But those beds could swing. I mean, I wasn't thinking about it that way. I had this image of them all being for youth with medical problems.
Oh, yeah, sorry.
That's what I was trying to clarify.
Yes, absolutely. Could also be, if somebody is appropriate for inpatient care, somebody with a developmental disability or something like that as well. So, yes, it's not only, but that's what drove the need.
The location.
The initial conversation around the need for diversification.
And if I just want to add, do you have a sense of how many youth in the state need to be hospitalized because of psychiatric and medical issues at any given time?
We can probably find some additional data for you around that. Typically, it depends on when we say medical issue, how we're going to define what that medical issue is. Because somebody could have a broken arm, and that might be hard to staff on a unit, especially if that youth has a hard cast and is weaponizing, due to their treatment. Or it could be somebody who has untreated diabetes. We don't always get that level of medical information, but we could certainly look and see.
Yeah, I mean, we're a small state. I'm just trying to understand the scope of the problem. How big a problem, or is it? That's what I'm wondering.
Yeah, it's a good question.
Do you have a question?
Okay. Two that are interconnected.
Okay.
It's just some clarification after Representative Blumley's question, because we talked about the secure residential and that's moving to Essex, but that's run by state employees, correct? Not privately contracted out. So my question is, number one, can you give us at least one other example of an RFP, a request for proposal, where a private group, responded to the needs of the state like this one does? Can you give us an example? And then number two would be, have you looked at the possibility of the state opening a facility like we have the state hospital or like we have in the past? Because we closed Woodside, which was treating, youth, whatever. There might be, maybe there's some, and there's still a need for those youth. So, two questions, interconnected.
Sure.
Yeah.
So we put out RFPs pretty regularly and contract with private providers. And I think when we just even talking about the alternatives to EDs, those are all private providers, our DA system. A lot of our RFPs go to private providers.
And then the second question was, has the agency considered if a private provider can't do the work, the possibility of the state designing exactly what we think we need for, these youth or maybe others, like maybe some combined hospital for special needs, inpatient mental health, centralized,
Yeah, Agency of Human Services, that, obviously that includes us and DCF and VDH and numerous other interested folks, we are having conversations, DCF leads those obviously, on how to adequately serve youth who have higher needs. And so I'll defer that over to my friends at DCF, but we certainly have been engaged in conversation about what makes the most sense in serving all the types of youth that are interacting with the agency, state-run or private.
Great question.
Yeah, so all very good questions. This was a good
Yeah,
conversation.
thanks for your patience with us.
I think the general consensus for what we've talked about is we need some data to support what you're asking for on the population of youth. So that would be great to have that sooner rather than later. We have a deadline of getting back to appropriations on Tuesday, so we'll be having committee discussion on Friday and Tuesday.
Okay.
So sooner the better. And then for the committee, the hope is that we will have some people come in to testify from the hospitals on their thoughts on this proposal, since it is youth waiting in emergency rooms is who we're hoping to help here. So we'll hopefully have some testimony from the hospital system on Friday. And then we did not cover everything. So I'm going to rely on Daisy and Alyssa to work with TIF and DMH on the questions you need to come back and talk to us, the committee, on Friday of the items, unless you're all available for about half an hour, or someone is available half an hour on Friday, that you could come back and we could just cover the remaining pieces. So if you can make that work, that would be great. If you can't, I understand that, and Daisy and Alyssa can work with you offline.
We can check schedules, yeah.
Okay, great. So Claire will be in touch. So thank you again very much for your continued hard work for our Vermonters.
Those are great questions.
So we're going to have Claire loop us right into the Green Mountain Care Board testimony. We are not in the room, so they cannot hear us or see us. I would keep the video off, but they will know we're here. So you can be comfortable eating, stretching, standing up.
Put it in a headphone and walk and listen.
You can do whatever you want. We do have people who are going to go to the floor at 3:00, and that's great too. I plan to stay and listen to the Green Mountain Care Board after that. It's all up to you what you want to do. And so